part 2, the last part, last section before we test on Monday, which I know you all are looking forward to. All right, so how many slides am I asking here since you see you're scrolling? 18? Oh, less than 20. Give me 5-10 minutes.
I need to pass the section though.
There you go. Good point. All right, so what you were looking at is what's known as the oxyhemoglobin equilibrium curve. Sometimes it'll be called the oxyhemoglobin dissociation curve. Before I start explaining all the parts and pieces of it, what does oxyhemoglobin mean? Hemoglobin that's bound with oxygen. Yes, we can carry 4 maximum molecules of oxygen per each molecule of hemoglobin. So, this curve represents the relationship between the partial pressure of oxygen, hemoglobin saturation of oxygen, and oxygen content. Okay, so those 3 things, relationship between partial pressure of oxygen, oxygen saturation, and oxygen content. It shows that there is a non-linear relationship between that partial pressure of oxygen and hemoglobin saturation. It's not exactly linear, meaning if one goes up by 1, the other goes up by 1, and so forth. It kind of has this sigmoid shape curve, which, if I'm going to point out a few things about this, and I'm going to say the steep portion of the curve, and when I say something is steep, what do you think of? Going up quickly, or what if I'm at the stadium in the 400 level where it looks like I'm looking down at the field like this? Isn't steep also going down? I'm afraid if I don't pay attention that I don't trip and fall because things are so steep. Okay, so that could be going up or going down for something to be considered steep. When I talk about the flat portion of the curve, think of this as the edge of a cliff, the edge of a mountain. All right, clearly we see where the steep portion of this cliff or mountain is, and we see where the flat portion is. So what I'm about to describe is things that are happening in the steep portion versus things that are happening in the flat portion of this particular curve. It shows that in the steep portion of this curve, there's going to be rapid loading or unloading of oxygen. Rapid loading or unloading of oxygen. Where in the flat portion, there's very little. And what I mean by that is if you look at the difference in numbers, if you look at the difference in numbers on the steep portion of the curve, and again, I'm talking about this relationship. If I'm looking at the numbers on the steep portion of the curve, they dramatically change the further down or further up they go in this general vicinity, as opposed to they don't change very much up here, the flatter portion of the curve. To explain that a little bit further, the steep portion of the curve, which is colored green on the slide, okay, that's the steep portion of the curve. For example, changes in the PO2 between 20 and 60 millimeters of mercury. Okay, so at a PO2 of 20, that equates to a saturation of about 30%, or a PO2 of about 60 equates to a saturation of about 90%. There's a very large swing in oxygen saturation in this steep portion of the curve. Again, look at what's in green. Saturation of 30 to saturation of 90. Boy, there's a huge swing in the partial pressure of oxygen. If you look at the partial pressure of oxygen on the flatter portion of the curve, a PO2, say from 60 to 100, the saturation goes from about 90 to about 98%. A very small change in saturation. Everybody see that? Now this curve shows the PO2 going up to about 140. But if I place a patient on 100% oxygen, if I placed you on 100% oxygen, your PO2 levels I would expect to approach a 600 and something number. So this graph could continue on out to a PO2 of 600. But your saturation, is it going to continuously climb? No, it's all still going to be that flat portion of the curve. Again, right here, if your saturation is 98, 99%, it's hard to get much higher. Only can get to 100, you can't get above 100. Okay, that's that flat portion of the curve. So even dramatic changes in PO2 really do not dramatically change saturation. Remember the other day we talked about what's considered a normal oxygen saturation. Now according to the textbook, it used the number 97.5, or we can round up and call that 98. But didn't I say in the hospital setting, we look and say someone's normal at 95 to 100, and some folks would even say, well, I use 92 or 93 to 100. And I said even some folks will say, hey, as long as it's in the 90s, we're not sweating it. Saturation in the 90s, that means the PO2 is at least 60, which is, for the most part, acceptable. But remember what part of the curve we're on. Saturation of 90 to above, we're on the flatter portion of the curve. If I say I'm letting the sats go down into the 80s, now I'm getting to the steep portion of the curve. So the lower that sat can fall, the more dramatic my PO2 could fall. Okay, that's all we're looking at here with this flat portion versus steep portion of the oxyhemoglobin equilibrium curve. You can sit there and pick this. A PO2 of 60 equates to a saturation of 90. A PO2 of 40 would equate to a saturation of approximately 75%. All right, so we can use this graph, this curve, to predict what someone's PO2, if someone's PO2 is a certain number, what saturation should that equate to? Again, simply by using this graph or this curve. Something else this curve can tell us. It can tell us what the patient's P50 is, what their P50 is. Now what the P50 represents is this is the oxygen pressure when 50% of the hemoglobin is saturated. Normally, that's a PO2 of about 27 millimeters of mercury, is when half of our hemoglobin is saturated. Now, by knowing the P50, is the P50 number higher or is it lower for this particular patient? That lets me know hemoglobin's affinity for oxygen. And would hemoglobin rather carry oxygen or give up oxygen? Maybe not carry so much oxygen. All right, so what's P50 represent? That's the pressure of oxygen where how much? 50% of the hemoglobin is saturated. That's the P50. And it lets me know hemoglobin's affinity for oxygen. Affinity? What does affinity mean?
Its ability to
Gets the line, gets closer. It likes it. It likes it more. And again, likes what? Oxygen. Okay? Does this hemoglobin like oxygen? Does it want to hang on to oxygen, or does it want to get rid of oxygen? That's what the affinity is. Yeah, I don't have a very strong affinity for Jeremy. I don't want to hang out with him. But Autumn's cool. Autumn's cool. As you boo me, right? You know, feelings mutual. Thank you. All right, so affinity means hemoglobin's affinity for oxygen. Now, things could change with the patient that changes hemoglobin's affinity for wanting to carry oxygen or not. Speaking of which, and I know that some of these slides and these graphs can be very, very busy, but I'm telling you what I'm going to test you on, okay? So, if I can look at the oxyhemoglobin dissociation or equilibrium curve and can see how it's supposed to look, okay, how it's supposed to look, what's here in red, but certain things could cause my curve to shift to the right or shift to the left, okay? And all that means is it's changing hemoglobin's affinity for oxygen. Now the specific things I'm not gonna ask, okay? The specific things listed here, you see all these arrows going up, all these arrows going down. I'm not gonna ask those specific things, so don't worry about those right now. But those are the things when somebody, because invariably somebody asks, well, what could cause it to shift? It's on the slide, right? It's on the slide. I'm not going to ask those specific things yet. Those will come in time. But certain things that could happen could cause the curve to shift to the right, where hemoglobin doesn't want to hang on to the oxygen, it wants to release it, wants to give it up to the tissues. Or certain conditions, and you can really see it's the exact opposite of these things, causes the curve to shift to the left, which increases hemoglobin's affinity for oxygen. Meaning hemoglobin wants to do what to that oxygen? Hang on to it, not release it to the tissues. Now, where does it need to be? Well, it needs to be right where in the middle, right where it's supposed to be, the proper affinity. But things that could occur could cause the curve to shift to the right, shift to the left, and that's going to change hemoglobin's affinity for oxygen. Make sure I don't have another slide.
So I just want to make sure I'm correct.
Yep.
That whether it goes to the left, shifting, or to the right, that's not what's making, left is not high, right is not low, or vice versa. It's the fluctuation in the numbers from
Correct.
where they fall.
Correct. The
Okay.
affinity for oxygen. The affinity hemoglobin has for oxygen.
Okay.
Let me give you, sorry, go ahead, Connor.
So a right shift is a higher affinity and a left shift is a lower affinity?
A right shift has less affinity. Hemoglobin has less affinity for oxygen, meaning it wants to get rid of it. A right shift. A left shift has hemoglobin has a higher affinity for oxygen. It wants to hang on to it. I'll give you an analogy, an example to help you remember that. My analogies have to revolve around what?
Baseball.
Baseball, thank you. Okay, I am right-handed. So think of me, and this could work if you've ever put on a baseball or softball glove before. And let me add, you're right-handed. If you're left-handed, you're screwed. This analogy doesn't work for you. I'm sorry. You have to come up with your own. But I have a glove on my left hand. That's what I'm going to catch the baseball or softball with. And I'm going to throw the baseball or softball with my right hand. The baseball or softball represents oxygen. If I give up the baseball, that's a right shift. Notice I'm right-handed. I'm giving up oxygen to the tissues. A right shift. You throw the baseball back to me, I catch it with my left hand, my glove in my left hand, that's a left shift. What am I doing to the ball? I'm hanging on to it. Okay? So that may be an easy way. It's how I remember it, and I share those things with you guys. Again, if you're left-handed, this totally is back asswards. I'm sorry. But a right shift, hemoglobin does what to the oxygen? Gets rid of it. Decreased affinity for oxygen because it wants to get rid of it. A left shift, increased affinity for oxygen, it wants to hang on to it. And again, I'm using the baseball or softball analogy. Okay.
So do we want it to have a low affinity so it goes on to the tissue?
I want it to have perfect affinity. You know, I don't want a right or left shift. I want it to be where it's supposed to be, smack dab in the middle. Okay? But certain conditions, certain conditions can cause the curve to shift. Again, not getting too much into all of these. Let me use one as an example. Increased temperature. Think about your metabolism when you have a fever. Does it slow down or does it increase? It increases. Your body's going to want what? The oxygen. So the hemoglobin's going to do what? Shift to the right. Oh, I guess I should shift to your right. Shift to the right and give up more oxygen. But what if the temperature, what if you're out in the elements in a cold weather environment where your body's going to hang on to the oxygen and not rapidly give it up? And that's just simply based on body temperature. We'll go through in time some of these other things. And again, I'm not going to ask temperature specifically on the test. Right now, what I want you to be able to tell me is a right shift, what's the affinity for hemoglobin for oxygen, versus what's a left shift, hemoglobin's affinity for oxygen. Shift to the right, gives it up, decreased affinity. Shift to the left, hangs on to it, increased affinity for oxygen.
The normal will be like around the 27, will be the 27.
A normal P50 is around 27. But if that number climbs, it's higher than 27. For our patient today, it's 37. It's a shift to the right. Different patient, Instead of 27, it's 17, it's a shift to the left. And you can know that simply by knowing simply what their P50 is. This P50 lets us know the affinity hemoglobin has for oxygen. Yeah, I know.
Okay, just to clarify with this.
Yeah, go ahead, please.
So you're not asking, at the current moment, you're not asking about the first bullet point for either, just the second one?
Yeah, I'm not asking about anything here, but I am asking about hemoglobin's affinity for oxygen. Hemoglobin's affinity for oxygen. I'm not asking specifically about what the P50, if it shifts to the right versus the left, but I am going to ask questions about what does the P50 mean, okay? But not necessarily what causes it to shift to the right or left. But it's the same thing that causes the curve to shift to the right or left. So I don't think adding this is much more difficult to add if you know what the right shift versus left shift means. Tom?
So the P50 is at this moment, there's 2 oxygens on the hemoglobin, or 50% of the hemoglobin is fully saturated.
That's it. 50% of hemoglobin is saturated.
Okay.
Yeah, it doesn't mean, I'm glad you asked that. It doesn't mean that that one only has 2 of the 4 seats taken up. No, it just means half the hemoglobin is saturated with those 4 molecules of oxygen.
You said that hemoglobin, it's like an all or nothing type of situation.
As far as the oxygen molecules hopping on board. So when one hops on board, and what was that term? When one hops on board, the other 3 rapidly hop on board. And when
Uber.
one goes off, the other remaining 3 rapidly go off. What was that word? Starts with a C.
Oh.
Did you say Cooper? Was it Uber? All right. Uber. Uber binding. Yes. Cooperative binding. Cooperative binding. Uber binding. I like that.
So,
I need some more rideshare examples. So Uber, Lyft. I'm sorry.
Yeah, that's fine.
Okay. Hang on to it. I'll get plenty of time here at the end to talk about it. So let's, if you don't mind, let's step away from the curve for a little bit. If you don't mind, all right?
You are such a liar.
I promise you what.
you promised no new formulas
I don't
today.
remember that.
Actually,
That's
yeah,
crazy.
it's
That's
recorded.
crazy.
I don't recall that. So much technology today can be manipulated. You know, AI can change what I said. You know, I don't believe anything. So, nevertheless, PO2 saturation hemoglobin. We talked about that the other day and how important that was for what's John's second favorite formula of all time? Total oxygen content. So still, knowing that doesn't provide full assessment of adequacy of a patient's oxygenation. Blood flow still has to be adequate. I can have great amount of oxygen in the bloodstream, but if the heart's not pumping and it's not moving that blood around, my patient's still going to suffer. Not all of that oxygen can be delivered. So, things that could affect oxygen delivery, of course, is the stuff we talked about from the other day. That's total oxygen content, but that will also be multiplied by the patient's cardiac output. Now, cardiac output simply, again, is the heart pumping a certain volume of blood out of the heart per minute. Okay, out of the heart per minute.
That's the same abbreviation as carbon
Yeah,
monoxide, doesn't it?
carbon monoxide.
Yeah, well, the official abbreviation is supposed to be Q. I know. It's supposed to be Q. So I said, I'm trying to simplify this as best I can. So I'm just going to put the abbreviation cardiac output. I know CO is carbon monoxide, and that's why we don't use CO technically for cardiac output. We use the abbreviation Q.
Is your third favorite?
As far as
Formula?
ranking of John's favorite formula of all time, I would say it's not even in the top 10. That being said, you are not going to have to calculate this, okay? You're not going to have to calculate it, so I did not lie when I said there's no new formulas to study, meaning implying there was no new math you're going to have to learn, because I'm not going to ask this specific equation, but take into account what is accounted for in oxygen delivery, not only total oxygen content, all of these, but additionally blood flow or cardiac output. That I could ask, but not specifically this equation. But O2 DEL, oxygen delivery.
So that's the same as DO2.
Yes,
And this-
yes, yes. That's what they, that's, I didn't make up, I promise. I did make it this one. I did not make up this abbreviation. This does represent oxygen delivery. Okay. So I'm not gonna put any numbers here. We're not gonna have to solve this. This is not another formula calculation you're gonna have to worry about solving at this time. At this time. All right, so if oxygen delivery depends on total oxygen content and cardiac output, then that means normal oxygen delivery is how much? This, we talked about this the other day. 1,000 mLs. 1,000 mLs of oxygen are delivered every minute. That's normal oxygen delivery. As far as what the body consumes or takes, well, guess what? There's another initial for that. Oxygen consumption is about 250 mLs, again, of oxygen per minute, which equates to what percentage? 25%. This is the same stuff we talked about from part 1. So none of this really is new, maybe just some terms here. So oxygen delivery, oxygen consumption. Oxygen delivery again, oxygen consumption. If delivery is reduced, so if we reduce what is normally provided, delivery is reduced, or there's an increase in oxygen consumption, then the amount of oxygen getting to the tissues is going to be inadequate, insufficient, not providing the tissues, not providing the body with enough oxygen. But my question is, what do you think would happen when you exercise and your muscles need more oxygen? Because again, that 1,000 mLs per minute of oxygen is at rest. If I say, let's run up the stairwell 3 or 4 times, my body's going to need more delivered so it can consume more. So what would my body have to do?
Breathe faster and deeper.
Okay, I could see that. Okay, so my body could breathe deeper and faster, yeah, but something else.
Why don't you just utilize what's already in the blood cells?
The cardiac output is going to have to increase. And again, we all understand that. If I start exercise, you know what's going to happen to my heart. My heart's going to start beating harder. It's going to start beating stronger. So it can do what? Move more blood, which in turn is moving and carrying more oxygen. So during, again, normal oxygen delivery at rest is how much? Delivery? 1,000. But with exercise, with increased effort and need, it could easily get to 4,000. Again, by my heart beating more frequently, beating stronger, to try to, again, move more blood. Again, oxygen's being carried in the blood, to be able to get that to the tissues that need them. And so again, that previous slide, oxygen delivery is 1,000, oxygen consumption is 250. That's true, but that is, again, to emphasize, at rest. With exertion, with exercise, both those numbers could go up. So let's just hypothetically say my oxygen delivery is 4,000 liters of oxygen per minute, and if the body still takes, what percentage? 25, then what's my new oxygen consumption? 1,000. Because with exercise, with exertion, my muscles, my body, my tissues need more oxygen, so they need more delivered so they can ultimately consume more.
Is that supposed to be milliliters per minute, or?
I'm sorry, yes.
Oh, okay.
That is supposed to be milliliters, correct.
That's impressive.
Or 4 liters, yes. I think I was probably torn between which number to use, and I ended up using 4,000. All right. Oxygen consumption, which again we said is 25%. Does that look like another formula to you? Oh my God, another formula, John. But one that I will not ask you to solve, okay? I'm not going to put numbers to this to have you actually have to do the math here. But there is a calculation to figure out what oxygen consumption. So at the patient's bedside, we could figure this out for this individual patient. Again, you know what CaO2 is, right? My second favorite formula of all time, total oxygen content. That's what we did the last time on Monday. What do you think this is? Venus. So where in total oxygen content we needed SaO2 and we needed P little aO2. With this, we would need SvO2 and PvO2. Again, I'm not asking you to solve this, so don't worry about these. But what oxygen consumption is looking at is it's comparing how much was ultimately provided versus how much was consumed. Looking at the difference between ultimately Ca and CvO2 to be able to see what the body extracted. Now, again, normally what is it extracting? About 25%. So when you hear the term O2ER, it's not emergency room, it's extraction ratio. Normally it's around 25%. But if you wanted to know what your patient's oxygen extraction ratio is, without making you do it on a test, there is a calculation for that. There is a way to solve for that. But you're going to need what? A patient's arterial blood, so we can figure out what this is. And you're also going to need what we call mixed venous blood to see what this part is. So that's not something I can easily obtain at just any patient's bedside. They're going to need some catheters, some lines in place. One, and I could draw from an ABG, but they're also going to have what we call mixed venous blood drawn as well. And we'll get to how we do all that stuff down the road. But no calculation, yes, it is a formula, but no formula you're going to have to solve. Yeah, okay. Just like the DO2, not something you're going to have to solve. All right, so normally oxygen delivery way far exceeds what the tissues need when it comes to oxygen. But in critically ill patients, however, oxygen delivery may fail to meet tissue oxygenation requirements. When this happens, we call this the critical oxygen delivery threshold, when the patient is not able to provide themselves with enough oxygen, with enough delivered oxygen. This critical oxygen delivery threshold, or DO2 crit for short. Levels below this lead to tissue hypoxia. What is hypoxia? Lack of oxygen in the tissues. And again, emphasizing by the word tissue hypoxia. There is just not enough oxygen there in the tissues. Now when that happens, lactic acid begins to form. Now that's something we'll talk about later when we can actually measure lactic acid levels, and when lactic acid levels are increased, that's an indication of tissue hypoxia. Now for normal cellular metabolism to occur, it has to be in an aerobic situation, meaning exposed to oxygen. So normal cellular metabolism is, we see aerobic metabolism occurring. Again, body's using the oxygen. But when we're not providing enough oxygen, metabolism switches to aerobic to anaerobic, which means it's occurring not in the presence of oxygen. And that's when lactic acid levels begin to increase. So anaerobic metabolism is metabolism when there's not enough oxygen present. When that occurs, lactic acid levels increase. So in time, we'll talk about what the numbers are for lactic acid. And when we find out, wow, this patient's lactic acid levels are significantly higher than what they're supposed to be, what does that mean? The body is not getting, tissues are not getting enough oxygen. Their tissues are deprived of oxygen, causing tissue hypoxia. It could be part of that picture, sure, part of that picture. And there's other things, we'll kind of get into some of them. The other day we talked about hemoglobin, its importance in total oxygen content. And so if someone's hemoglobin levels were low, would make sense to replace, give them some more hemoglobin, give them some more red blood cells. The more red blood cells, the more hemoglobin I have, the better ability I would have to allow my body to be able to deliver more oxygen to the tissues. And that's still true, don't get me wrong, that's still true. Blood transfusions are quite common, very common to give blood transfusions. Give a patient red blood cells, blood products. But when should a patient receive a transfusion? Now, if we look at the textbook definitions for anemia, for a man less than 13, for a woman less than 12, okay, textbook definition doesn't mean just because it's less than normal that that patient has to receive a transfusion, okay? They've done studies looking at blood transfusions for patients who are anemic at various hemoglobin levels that are much less than normal. Used to be, if it was a single digit, like they got under 10, we used to transfuse. Studies have shown that it really doesn't improve mortality, but where it does improve is if hemoglobin levels are down to 7 or 8, which is about half of what our normal hemoglobin is. So I do want you to remember this number, because this number represents when blood transfusion should be occurring. But what if somebody's anemic, textbook definition anemic, and their level's only 10? Okay? We're not recommending to transfuse them, to give them additional blood. Now, if you're anemic, what are the things that they could recommend us do to try to improve? Supplement, iron supplements, eat more red meat, that sort of thing, to try to increase our hemoglobin levels. But in a critically ill patient, ICU patient, yeah, I can't say, well, we'll call Texas Roadhouse and bring a couple of sirloins here. Can't do that, but they can give intravenous iron supplements, that sort of thing. But in the interim, we'll still monitor and watch those levels, but if hemoglobin levels fall below 7 and 8, then it's recommended to give them a transfusion, give them blood products. All right, cyanosis. We've defined cyanosis numerous times in the past already. Here at the midway point of the semester, we've said cyanosis umpteen times in a couple of different classes. And we know it's that bluish discoloration of the skin. Could affect the periphery, the fingertips, the toes, could affect the core, the central portion of our body, mucous membranes, etc. But I want you to know the actual textbook definition for cyanosis. Now, when oxygen leaves our hemoglobin, the hemoglobin does change color. If hemoglobin is carrying oxygen, the red blood cells stay more red, brighter red in color. But when the oxygen leaves the hemoglobin, the color turns more purplish or bluish. Hence the reason they're appearing blue in color. But the textbook definition for someone to see cyanosis is when an individual has a desaturated hemoglobin level greater than 5 grams per deciliter. Now remember what desaturated hemoglobin means. This is the hemoglobin that's not carrying oxygen. Right? It's currently not carrying any oxygen. And we know for us, there is some hemoglobin that we're carrying that's not currently carrying oxygen, and that's okay, we're fine. But it's when that number exceeds 5 grams per deciliter, 5 or greater grams per deciliter of deoxyhemoglobin, that the patient will appear cyanotic. They will appear blue in color. And that could be their periphery, that could be central, meaning the core, the mucous membranes, their lips, their tongue, could appear blue. Now here's the flip side. So with cyanosis, we typically would, if we see someone with cyanosis, we would say, just looking at them, they're blue, we would probably say, they're just not getting enough oxygen. That's why they're blue. That could be a true statement, but not every patient who's hypoxic will be cyanotic, or vice versa. You could have a patient who actually appears blue, and they're technically not hypoxic or hypoxemic. Reason being, it depends on their blood count. A patient who is anemic, again, what does anemia mean? Low hemoglobin, low red blood cell count. Their blood count, their red blood cell hemoglobin count could be so low that they never could achieve that 5 grams per deciliter of desaturated hemoglobin. So that patient will never appear blue, even though they could still have reduced oxygen. Same token, a patient who's polycythemic, a very high red blood cell count, lots of hemoglobin, they could potentially have 5 grams per deciliter desaturated hemoglobin, appear blue in color, cyanotic in color, and not technically be hypoxemic. Again, if they're normal, then that's a different story. But if their blood counts are too low or too high, they could not or potentially could show cyanosis, even though their body technically is not hypoxemic or hypoxic. CO, and for this CO inhalation, I don't mean cardiac output. For CO means what again? Carbon monoxide. Patients with carbon monoxide, and we talked about this the other day, didn't we, with carbon monoxide and how hemoglobin would rather carry carbon monoxide than oxygen, has a much higher affinity, hemoglobin has a much higher affinity for carbon monoxide than it does oxygen. So if somebody's carrying carbon monoxide, obviously oxygen's not getting to the tissues. So tissues definitely could be hypoxic, again, lack of oxygen. But patients who have elevated carboxyhemoglobin, carbon monoxide bound to the hemoglobin, will not appear cyanotic. That carbon monoxide keeps the hemoglobin red. And so their blood will appear red. Their coloring will appear red, even though oxygen is not getting to their tissues. So that could be deceiving when you look at a patient going, well, their coloring is fine. They look pink, their mucous membranes are bright and pink, I don't see no signs of cyanosis. But if they're a carbon monoxide poisoning patient, and again, usually we can identify those as they come through the door based on current medical history. They were pulled from a fire or pulled from a garage with the garage door closed and an engine running where they were inhaling carbon monoxide. We tend to know pretty much based on their history what I'm suspecting here, but don't think that they're going to appear cyanotic in color.
So they're gonna appear like bright red or not?
They could appear bright red, yeah, but definitely not cyanotic, definitely not cyanotic. All right, so speaking of carboxyhemoglobin, all right, hemoglobin that is currently carrying carbon monoxide. So again, what was the word oxyhemoglobin? What did oxyhemoglobin mean? Hemoglobin that is carrying oxygen, saturated with oxygen. Carboxyhemoglobin, hemoglobin's carrying carbon monoxide. And again, like I said, for whatever reason, our body's an amazing thing, but this is something where it's kind of messed up. Our hemoglobin, look at the affinity, 210 times that hemoglobin has for carbon monoxide than it does for oxygen. For whatever reason. Hemoglobin would say, carbon monoxide, great, come on board, even though our bodies can't do anything with it. And basically replace the oxygen that normally would be carried by our hemoglobin. It also shifts the curve to the left. So any hemoglobin that is currently carrying oxygen, since the curve shifts to the left, what does hemoglobin want to do? Hang on to it and not release it. So again, that additionally deprives my tissues from receiving oxygen. Now what's the treatment? Well, number one, think about patients who have carbon monoxide poisoning, elevated carboxyhemoglobin. They're in some sort of environment, some sort of environment where carbon monoxide levels they're breathing in. Could be a fire. Could be in the garage with the car running, engine running. It could be we are going through a storm, we've lost power, and what are we running? A generator. And for whatever reason, we run the generator inside our home in a closed environment where it can't vent and escape. What's coming off that motor? Carbon monoxide. So, again, we're in that room, we're in that environment. Over time, we're inhaling more and more carbon monoxide. Our hemoglobin is saying, okay, yes, I'll carry you. To heck with the oxygen. I'm not going to carry oxygen. I'm carrying carbon monoxide. And of course, our body, our tissues can't do anything with that. So, when it comes to treatment, what should be the first thing we do? Even before that, get them out of the carbon monoxide rich environment. Get them out of the garage. Get them out of the home if that's where the carbon monoxide is built up. Get them out to some fresh air. Number one. Get them out of that environment. Get them away from the carbon monoxide. Okay? If you said give them oxygen, and granted we will, but I'm not gonna put the oxygen on them in that environment. I need to get them out of that environment first. So that's number one. If we left someone, we pulled them from a burning building, and the fire and the heat and all the damage that's gonna cause is something different we'll talk about later, but this is just inhaling the smoke, inhaling the carbon monoxide. You get them out of that environment, you put them out on the lawn, grass somewhere, out where fresh air is. It will take 4 to 6 hours before that carbon monoxide is reduced by 1/2. I didn't say 4 to 6 hours before it's all gone. I just mean before it's reduced by 1/2. We call that its half-life. 4 to 6 hours before the levels, and let's just make up a level, 50%. It'll take 4 to 6 hours before that 50% carbon monoxide becomes what? 25, before it would be cut in half. Now it's 25. It's going to take another 4 to 6 hours before that 25% is cut in half. Well, 12 and a half, something like that. Okay, so be careful when we use the term half-life. That means before it's reduced by 1/2, not when it's eliminated completely. But once I get them out in fresh air, if I put them on 100% oxygen, give them all that oxygen, that's going to help over time get rid of that carbon monoxide and replace it obviously with oxygen. It reduces the half-life to just a little over an hour, about 80 minutes. Again, let's just pretend their carbon monoxide level is 50%. It's going to take now 80 minutes before that amount gets cut in half. And another 80 minutes before that level gets cut in half. So still, it's going to take time. If we could put them in a hyperbaric chamber, where we raise the barometric pressure, notice what can happen to the half-life, 22 minutes. So obviously, number one, get them in fresh air, but that's going to take a half-life of 4 to 6 hours. 100% O2, it's going to take over an hour, about 80 minutes. But if we can now put them in a hyperbaric chamber, that's going to reduce it to 22 minutes. So think about on the one end, at least to get them out of the smoke-filled environment, 80 minutes, or 4 to 6 hours in fresh air, to 80 minutes to 22 minutes when it comes to the half-life. And not every place has hyperbaric therapy, but if our hospital does, then that's definitely a place to hurry and get that carbon monoxide out of the patient's system. It's going to work faster. But at the very least, even the hospitals that don't have a hyperbaric chamber, we all have 100% O2. And I know when fire rescue picks up that patient, what are they going to put the patient on? 100% O2. When they're showing up to our ER 10 minutes after they were extracted or removed, 10, 15 minutes after they were removed, they've already been on oxygen for at least a little bit of time, helping to reduce that half-life.
I wonder if there's like an evolutionary thing for the affinity to carbon monoxide.
Probably. What? I have no idea. But again, our body cannot use carbon monoxide. Again, and it takes up the place where most all of our oxygen is being transported. Again, what percentage of our hemoglobin is carrying oxygen? Or our oxygen, most of it's carried where? In the hemoglobin, right? What percentage of that? 98% versus how much is in the plasma? 2%. About 2%. So again, if we're saying 98%, that's where most of the oxygen is being carried on the hemoglobin, but right now it's carrying carbon monoxide. Again, there's not going to be enough oxygen getting to the tissue.
Definitely a toxic relationship.
Yeah, very much so, very much so. But it still would rather carry carbon monoxide than oxygen. So, speaking of hemoglobin, more booze here for hemoglobin. And maybe not necessarily the first one here. Fetal hemoglobin. A fetus's hemoglobin is different than yours and mine. In utero, when they're in the womb, the baby will have fetal hemoglobin, which has a higher affinity for oxygen. And that's what helps pull the oxygen from mom to the baby. Again, because the baby has fetal hemoglobin. Part of the reason it helps to kind of pull that oxygen from mom to the baby. Again, much higher affinity for oxygen. Again, a shift to the left, Higher affinity wants to hang on to that oxygen, wants to grab hold of that oxygen. This next one, methemoglobin. You may hear the term methemoglobinemia used from time to time. This is when the hemoglobin structure chemically changes. Now, I don't care that you know the first bullet point changes from the ferrous to the ferric state. That really doesn't matter. But it chemically is altered where it can no longer carry and deliver oxygen to the tissues. So just like we said with carbon monoxide, at the end of the story, oxygen can't get to the tissues. With methemoglobin, oxygen can't get to the tissues either. Now, it's due to a chemical change, chemical structure change of the hemoglobin, where again, it can't deliver oxygen to the tissues. Generally from some sort of poisoning, generally from nitrates. So there are certain products that have nitrates in them that one of the, and I'm going to say very rare but possible side effects could be changing your hemoglobin to methemoglobin. Something that's quite common, nitroglycerin, common drug used by our heart patients. One of the extremely rare but still possible side effects is methemoglobin. Anybody heard of the term lidocaine? The dentist, we get Novocaine. One of the very rare but possible side effects, methemoglobin. Again, where your normal hemoglobin suddenly chemically changes its structure, where it can no longer deliver oxygen. Now, I will say, when we do encounter a patient who has methemoglobinemia or has elevated methemoglobins, and they haven't been diagnosed yet, we will be the first ones to know. We will be the first ones to know. As long as we're getting a blood gas. If we're not getting a blood gas, then it's going to be hard to identify this. But when we get a blood gas, because again, we're the ones who draw the blood gases. When you draw arterial blood, what color should it be? Bright red. Again, as long as it's carrying oxygen, but again, we see patients who are very sick in the hospital and their blood's not as bright red as it's supposed to be because their oxygen levels are decreased. We could accidentally draw blood from a vein where the oxygen's already been removed, or most of the oxygen's been removed, and so that blood could come out a little bit darker in color. That could be an inadvertent mistake when we're drawing an ABG. We actually accidentally draw from a vein. The blood looks darker in color. We tend to know the second we see the blood going, that looks venous. That looks like venous blood. Another thing we know when we draw arterial blood is it's under higher pressure than venous blood. So we see the blood rapidly fill that syringe. I know, yep, I tapped an artery because I'm seeing that blood automatically fill into that syringe. If I was hitting a vein, it's going to fill in very super slow. So with this, I know I drew arterial blood. It filled in there very nice, very quickly. Except the blood color, and this picture still doesn't do it justice. The blood color is extremely, extremely dark. Sometimes you hear the term, the blood looks chocolate brown in color. Now initially I see that as I'm drawing a blood gas, I'm like, oh, I drew venous blood. This has to be venous blood. But I say it's not because it fills in so rapidly, because it's under pressure, it's from the arterial system. Methemoglobin blood will appear very dark, almost chocolate brown in color. I had a student say one time, like pudding. Not as thick as pudding, but definitely darker in color. Definitely darker in color. And so that's why I say it's the respiratory therapist that probably knows this before anybody else, because you drew the blood. Now I'm still going to have to go analyze the blood, and I can see when I run it what this level is. But trust me, as I'm drawing the blood, I'm alerting the staff, I'm alerting the nurse, if the physician's around, hey, I think we have methemoglobinemia here. Give me a few minutes to run it, and I'll tell you what the numbers are. But in the meantime, we could start getting the antidote or the treatment for it to help to reverse it. It can be reversed very quickly, but we have to be able to identify it first. Again, extremely rare cause, but it was actually funny. This was a couple of years ago. I got a text from a student I haven't heard from in several years. And her text was, guess what I got to see today? It was methemoglobinemia. And she said, she worked in the ER, one of our local hospitals, and even the physician didn't know what it was. She said, I felt good because I got to explain to the physician what this was. Because again, it's something so rare. You rarely see it. I've seen it twice in 28 something years of being a respiratory therapist. And still, you hear of it once in a while, but definitely not often, because it's not a very common thing. And so it was really cool to hear from this former student of mine saying, yeah, I'm the one who identified it, and the physician had no clue. He had to go research it.
I'd be like, I need a raise. I'm just paying you.
I would. Yeah, absolutely. My value I'm bringing to the team here. Of course. Of course. What?
Hemoglobin differential.
There you go. I like that. Now, when we start looking at what the values are from the blood gases, it's not uncommon for us to have a certain level of methemoglobin, but it's going to be extremely small. That's why I say on here less than 1%. I had a student one time get the result. It wasn't as a student. They actually had to get a blood gas drawn, and they're like, "Why is my methemoglobin 0.2?" I'm like, that's okay. It's normal. That's normal. You said 0.2, right? You didn't say 2. 0.2. Okay, that's nothing. That's nothing. But that's a very rare but unusual situation that we can see, and it is related to the hemoglobin. It's an abnormal hemoglobin. Sorry, go ahead.
Going back to the fetal hemoglobin, is that why babies can go blind if they're given too much oxygen after birth?
No, that's different. That's different. But we will talk about that specifically in
Like the
time.
neonatal class?
Yeah, definitely in that class, but we'll talk about it a little bit. And you guys have already talked about some of the hazards of O2 therapy, but that's definitely one of them. But yeah, this not from this. Because this is in utero. When the child's born, the fetal hemoglobin quickly converts to what they call hemoglobin A, normal hemoglobin.
Is it because they're getting the oxygen from their own lungs instead of getting the oxygen?
That's part of it. Yeah. Yeah. It's just in utero when they have that fetal hemoglobin. All right, sickle cell hemoglobin. That's another abnormal hemoglobin. Now, the sickle cell hemoglobin tends to change its actual shape upon deoxygenation. Meaning when those hemoglobin molecules hop off of the hemoglobin, that's the opportunity for the hemoglobin to change shape. Now normally, hemoglobin is nice, smooth, round, it moves through our blood system very easily. When it changes shape, it forms this sickle shape. Now what happens as the blood vessels narrow, it reaches a point where it all starts to conglomerate, stopping or slowing blood flow, where it's all getting kind of caught or stuck. Can lead to extremely painful situations for patients, depending where it's stuck at. But I guess on the flip side, the worst thing is it can cause a blood clot. So it could cause a blood clot in the brain, which could be a stroke, could affect the lung, a PE, could potentially in the coronary arteries, lead to a heart attack. So having sickle cell hemoglobin is not a good thing, not an appropriate thing. The sickle cell itself is extremely fragile and could rupture easily, and that can in turn lead to anemia for a patient with sickle cell hemoglobin. There's folks with sickle cell disease. They know they carry that trait, that gene, and they're prone to developing a sickle cell crisis. For those individuals, they do have to be careful. They have to watch themselves because it can be worsened by prolonged episodes of hypoxia. Now that's something we normally don't cause for ourselves, hypoxia. But what if I'm a workout nut and I really push myself too hard, right? Really exert myself, and now my body's not getting enough oxygen because I'm working out so hard, exerting myself physically so hard, I can cause my hemoglobin to change its shape and go into that sickle cell formation. So, not to say someone who with sickle cell can't do the things they normally want to do physically, of course they can, but they just have to be careful. There was, and when I say this, every year I say this, I use this example as an analogy. There was a former football player, I think he's in broadcasting now, Ryan Clark.
Oh, yeah.
He played for the Steelers, he played for a couple different teams, but I remember this occurred when he played with the Steelers. He was playing in Denver against the Broncos, and the high elevation, playing football at elite level, he had a sickle cell crisis, nearly died from it. So the following season, I think he was on a different team at that point, his team, or maybe he was still with the Steelers, I can't remember, but at some point later after that, his team was playing in Denver. His coach told him, you are not playing. We're not gonna risk you and risk you getting hurt. Death from having that condition. Again, he could still compete at the elite level, but why push it in that elevated altitude that Denver has? And could lead to potential hypoxia, which then could in turn lead to a sickle cell crisis for him. See, I saw a hand out of my periphery. All right, any questions? Was that my last slide? 18 slides, that wasn't too bad. And there was no math. As opposed to the 60-something with the first class, right? Lots of pictures on that first class. Give me a break on that one. Lots of pictures. All right, so I do have a few questions for you guys. So first question, which of the following levels of PO2 is associated with sharp decreases in oxygen saturation and content? Less than 20, less than 60, less than 80, less than 100. Again, partly again, when you think about this curve, oh, there goes my pen. Think about that curve. When does it hit the
27.
When does it hit the cliff portion? PO2. Remember, PO2 was this horizontal axis. About 60. Very good. So less than 60, they're right over here on that curve. Meaning levels less than 60, sharp decreases in oxygen saturation and content. What's the 27? I'm making sure I'm not asking that question. Sorry. What's the 27 number? What's that P50 represent?
It's the PO2 when hemoglobin is half.
That's the PO2 when the hemoglobin is 50% or half saturated, yes. And again, as that number changes, that just tells me affinity hemoglobin has for oxygen. All right, so this one, make sure you get the right answer. This one was B. This one was B, 60. Next question. Which of the following factors affect oxygen delivery to the tissues? Hemoglobin concentration, oxygen saturation, cardiac output, plasma PO2, or all the above? It is all the above. It is all the above. All of those affect oxygen delivery. Okay, here's a good question. See if you guys know this. Under resting conditions, what percent of the arterial oxygen content is extracted by the tissues? 25, 50, 75, or 100%? 25. Under normal resting conditions, about 25% of what's delivered is extracted or is taken.
Isn't that also with exertion too? 25%?
Generally, but there could be times where your body actually needs a little bit more. All right, how about this one? Is the gain in blood oxygen content when PO2 increases from 40 to 60 millimeters of mercury greater than, equal to, or less than the oxygen content gain when PO2 increases from, say, 100 to 120? Greater than, equal to, or less than? And greater than? Equal? Part of it, and of course this will not appear on the test question, but if I give you that and ask the same question, is the gain in blood oxygen content when PO2 increases from 40 to 60 greater than, equal to, or less than when it goes from 100 to 120? So there's the difference between those two numbers. There's 100 to 120. What did I say? 40 to 60. As opposed to difference between here and here. Greater than? Greater than. Greater than. And again, it's looking at this slope of the curve. Anything down on this portion, especially anything less than 60, now you're on that steep portion of the curve. Anything above 60, again, very small increases in saturation and or oxygen content. Like I said, if I ask this question or some version of this question, I'm not going to give you this to look at, right? I'm not going to give you this to look at.
Of course.
And so I could pull, so instead of using 40 to 60, what if I said from 20 to 40? Or 30 to 50?
Still greater.
Still greater than.
You could
You know,
replace-
anything over on this side, kind of that red side, again, those are very small increases in saturation or oxygen content. Questions? No? Okay, so what mathematical calculations will you need to know for the test?